So now I invite Dr. Shruthi Tara. Uh, she's a senior consultant oculoplastic surgeon from Shankar Eye Hospital, Coimbatore. She has come all the way from there. I'm really glad on that. And she'll be talking about malignant melanoma and a typical presentation.
Thanks, Indu, for having me here and Team Drishti. Indu told me about this and common turns uncommon, but I'm not really sure the case that I'm going to talk whether it is common turns uncommon or uncommon turns uncommon. So we'll just see that. For the present state for it to go, I have to go back a little bit and tell about this patient. So he came in during COVID when it was in its peak. He was 8 months old at that time. He was referred for evisceration and diagnosed elsewhere, even radiologically, as anterior staphyloma. So I got a letter saying that those days nobody was they were operating at all. So that was the time when this baby came in. So, um, so that was this thing. But this was how it was when this was a baby when this picture was when he was 5 months old. So he had proptosis. There was a very dark discoloration of the sclera, which doesn't really gel well when you say that it is staphyloma. It doesn't look this dark, the staphyloma. But again, congenital, even if you think malignant melanoma, you don't really think congenital malignant melanoma is something which you really it just doesn't go into your mind. So, but he also had several raised cutaneous nevi. But didn't fit into any dysplastic features. So other symptoms, everything was normal. And so I did an EUA, and you can see that that was his cornea. So when I pulled the globe on, so you can see this is his cornea, and this was the mass. So it was there all on all the three quadrants, sparing the temporal quadrant. And this was an ulcerated, very thin ulcerated area. And the IOP was rather high and the cornea was very hazy. I couldn't make out what was there behind. So MRI did not show any typical mass, but in the T1 weighted image showed a little high signal area corresponding to that nodulo-ulcerated area which was there. So I did an enucleation with myoconjunctivalization and fitted in a 16 mm implant. Later on, he had a customized ocular prosthesis, and I managed to remove the entire without any spillage. Okay, so there was a pigmented melanoma cells in the choroid, and we got a second opinion on this because when they said congenital malignant melanoma, I was not really so convinced, but then the second one also came as the same thing. And there was pigmented melanoma cells in the choroid. The tumor cells were large with residual chromatin in the nucleus and very prominent nucleoli. And we did an IHC, which came as S100, HMB45, and melanavis positive. So that kind of gave us a thing that this is malignant melanoma. All right, so everything else was normal. And the child was kept on very close follow-up because he didn't have anything, no other signs that could say that, it is metastasized. So we kept the child on close follow-up. We made a protocol, discussed with Dr. Carol Shields, and then the protocol was formed. We made MRI brain orbit quarterly till the age of 1 year, then half year up to the age of 5. MRI liver and liver function test half yearly, PET scan annually, and ultrasound abdomen annually. This was the protocol that we formed. And 2 years, he was fine. He came to me regularly as told, and he was quite okay. So the take-home message is like very, you should keep that as a differential diagnosis. Histopathology is mandatory, and immunohistochemistry is again very important. So when you are in doubt, you enucleate rather than eviscerate. So we even published this. Right, the story begins now. So what happened? I don't know whether it is an oversight or an overreaction, but the fear of recurrence is always there with malignant melanoma. It's malignant melanoma, so recurrence is very, very high. Okay, so I lost follow-up with this child. He didn't come to me for quite some time. And when I saw them last, what they told me was the eye looked a little small. So they were not very happy aesthetically. So they went to a local ophthalmologist and had an implant exchange done. And then he came to me at the age of 3 years and 10 months, inferotemporally migrated implant. There was a contracted socket with all bands. And you can see this was the implant that had migrated. So I thought, okay, we'll do a socket reconstruction with form, because he was not able to wear the prosthesis. He was just 3 years and, close to 4 years, and not wearing a prosthesis is not the way to go. So I decided to remove the implant. And then what happened? I opened the socket. I saw one black pigmented streak over the posterior Tenon's capsule. So, okay, so I did a wide excision biopsy. I didn't put an implant. And so you can see that was the streak of implant which was there. So again, sent for histopathology and immunohistochemistry. And what happened? HMB45 melanase 100 was negative. KS16 was 67 was negative. So there was no proliferative activity. Can I just almost over?
You have time, enough time. Yeah.
Okay, yeah. And SOX10 was positive, so it said a melanocytic origin. CD68 was positive, it was melanophagous. And HNE said there was no ATP or mitosis. So this was not actually a recurrence, but a benign melanophagous. So is extremely rare, and clinical suspicion should be balanced with histopathology, and immunohistochemistry is mandatory. And every shadow deserves, you have to a second look at it. And I couldn't resist this picture. This is him when he's 6 years old, and so far so good. But then again, we can't really say where a single cell is lurking and when it would come, despite all the PET scan, despite liver function test or scan or whatever we do, a single cell might. So they should be on constant follow-up. Thank you. Anything, Fairuz, do you have anything, Dr. Ani, anything to add on to this? Because I was so very, melanophagous. I was like not so very convinced, because malignant melanoma is something that you think that has to recur, and that to a child. He's now about 6, close to 7 years. But when I saw that, I was almost sure, and my heart sank, thinking this cute little child, he would come and, that it is recurrence. But it said as melanophagous.
It could also be a melanoma arising from a melanocytosis that the child had, right? Yeah. In your pathology, there was extraocular extension?
No, there was no. The only thing that I showed you was on the sclera, and I was able to remove it without disrupting the.
But scleral invasion was there.
Scleral invasion was there.
Invasion was
yes,
there.
scleral invasion was there. The optic nerve was okay.
Right, yeah.
A long stump of optic nerve, and that was.
Not really sensitive to radiation, but there are,
No, you can't.
Yeah, so I don't know. You might have discussed with Dr. Carol also.
I did. No, I discussed
radiation
with so
is
many
one
of
of the option.
Radiation is one. Then some of them suggested a chemo.
Chemo may not be.
We
have checkpoint inhibitors and biologics now, where melanoma, extraocular extension, even prophylactically in United States after genetic testing.
Yeah.
Was a genetic testing done?
They were not too keen on that, the parents. So when I suggested that, they said they wouldn't want.
Yeah.
So
another thing, what I am doing a research in uveal melanoma now. Same kind of disadvantage that our patients are not able to do genetic testing. But something that you can really do, you can actually take out a slide even now. BAP1 immunohistochemistry. Not like BAP1 mutation, genetic
but
mutation, which is expensive. Immunohistochemistry is really cheap. So it is like BAP1 immunohistochemistry also, if it is positive, it comes in a poor prognosis list. So that is something that I'm doing now. And it's not expensive because I'm not getting fundings to, evaluate all the enucleated globe. So that should be considered in all our practice if we are doing melanoma. BAP1 immunohistochemistry, not genetic mutation. And that you can do even if you have the enucleated specimen now.
That I don't have, but I have the slides.
Just check with your, but it's been 4 years now, 6 years now. Yeah, you're right.
Close to 7.
Yeah. So, but some pathologists keep
He has it because this was so rare.
Correct.
So he has preserved it. I could probably
So
think
go
about
back,
that.
check with the pathologist whether he can do a BAP1 immunohistochemistry in his slide. Yeah.
Thank you.
And regarding systemic metastasis also, depending upon the genetic makeup. Now, genetics in melanoma has gone way beyond that we know in molecular and cellular level. It is basically systemic metastasis also that we are worried about.
Yes,
like almost 28 to 30% in 10 years. So still he has to be
He's
under
still,
follow-up.
yes, very much.
Right.
I'm not close
Yeah,
to
and
cases
another
yet,
thing
but
which I really want to highlight, which you have put there, we often think that eye is about MRI of the orbit, but in melanoma, including conjunctival melanoma, most importantly, MRI brain is the important thing for recurrence.
liver.
Yeah, brain is so important. Yeah. Thank you.
Thank you, Dr. Shruthi, for this